testimony and listening close to the testimony. I think there's some good things out there in testimony, but we're going to go live. You let me know, Carlo, are we live?
Yes, sir. We are not yet live. It is still booting up, so to speak. So
that's fine. I didn't have my hair
out
quite
there.
fixed yet. Okay, my hair's fixed. I'm good.
Okay, we're ready. We are live. Thank you.
Good morning, committee. Welcome to Labor and Health. Welcome to all the attendees this morning. A couple quick reminders. Make sure that if you're testifying and you're live talking to the committee, that your YouTube feed is turned off or all the way down. Otherwise, we get a lot of reverberation. I would remind you that the ability to come in and listen is available on the legislative channel. Committee will do roll call to start this morning. Right now, we're going to continue to follow our format that we've had. When we do the bill, when we get ready and get done with public testimony, we will move the bill. Because of our small number as customary, we're going to go ahead and go without a second right now. We'll talk about that when we come to live session and further. But for now, we'll follow that rule. We'll talk about that down the road again. We have two bills on our agenda. Likely, we will only hear one. We have until 9:30. The other bill, I think, will take longer to discuss anyway. I'd rather hold that until our next committee meeting. And I'm sure Senator Bouchard will appreciate that. The other bill requires a lot of discussion and will take longer than 15 or 20 minutes or a half hour.
Which one is that, sir?
That would be House Bill 4, I believe. Somebody can correct me.
Is the one we're going to discuss today?
It's on the list if time permits. We will not probably get to it. We will deal with Senate File 52 this morning and try to get through that one and get it in the pipeline. So with that aside, Carla, if you would go ahead and take roll for us, please.
Thank you, Mr. Chairman. Senator Bouchard.
Here.
Senator Furphy.
Here.
Senator Hutchins.
Here.
Senator McCune.
Here.
And Chairman Baldwin.
Here. Thank you, Carla. This morning, committee, we're going to hear Senate File 52, Insurance, Mental Health, and Substance Use Parity. If you've had time to read through the bill, you'll note that the bill is quite short. I will give you the pretext of the bill just up front and present the bill to you. It's pretty straightforward. What this bill aims to do is to, excuse me, mandate equivalent benefits and reimbursement related to mental health and substance use. Equivalent in causing parity between what's done remotely or via telehealth and what's done in person. Essentially, that's the context of the bill. Thus, it's quite short. We've done similar work with just regular healthcare, but this one specifically involves mental health and substance use. This came about because of COVID-19 concerns, and there was an increased use of telehealth, and that is the genesis of this bill. Without going item for item through the bill, you'll notice that the big context of this bill is right about the end, about the last 4 paragraphs before the end, just talking about inability to deny coverage for mental health or substance abuse, and that the charge of a copay or deductible or a coinsurance has to be consistent with what's done in person. We're going to hear a lot of testimony, both pro and con to this, and I don't want to spend a lot of time going through the bill. Are there any questions before we jump to any of the testimony about the bill, or any comments that you want to throw in about the bill?
Not yet.
I think it's a pretty straightforward, easy to follow bill and easy to understand it. It's not, all of our comments will not be favorable, all of them will not be against, but they're interesting comments, and I think they raise good points. So how many do we have in the waiting room, Carla, that wish to testify?
Mr. Chairman, we have 6 people.
Okay, let's go ahead and let's just put them all in, bring them all into the meeting, and we'll select their testimony as we go. We'll go ahead and admit them all.
Yes, sir.
They're appearing a few at a time. This is a little like elk hunting. I see one elk, and then I see 2, and then I see the whole herd. And for some days, I don't see anybody. Let's see,
File.
I see 6 in there now.
Oh.
There's Wendy and there's Tom. Everybody else has not got their hair fixed. They're not in yet. I think we'll hear first from the folks that are on boards or with agencies. I think we'd like to hear from Mr. Searles first if he's available. And I see his name, but I don't see a picture yet. There he is. I
Good morning,
recognize
Mr.
that.
Chairman.
Good morning. I recognize that wall from yesterday.
Virtual backgrounds are a wonderful thing. Very
Very good. Mine are all virtual. Mr. Searles, we'll go ahead and start with you this morning. We've walked through the bill. If you were listening, we walked through it briefly. It's a pretty straightforward bill. Language is pretty straightforward. It's a short bill, 1 page. With that in mind, we will ask for each of the presenters to go through and tell us their thoughts on the bill, et cetera, whatever you've got to share with us. So we'll start with you.
One page.
Introduce yourself and go forward.
Thank you, Mr. Chairman. I'm Greg Searles, the Executive Director for the Mental Health Professions Licensing Board. I actually have no testimony on this bill. Was actually more prepared for House Bill 4.
Yeah, me too.
Okay, if we're really fast, which I don't anticipate, we may not get there. We
Yes,
may
sir,
get
I understand.
We will see. Thank you very much. Stand by. I'm sure you'll have some comments as we go forward. Ms. Somerville, would you like to step up to the plate?
Good morning, Mr. Chairman and committee members. Thank you. Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers. And excuse me, I want to start with kind of just a quick overview of where we've been during the pandemic the last year and where we were before that with telehealth in terms of mental health and substance use services. So prior to the pandemic, I don't know if all the committee members are familiar with the Wyoming Telehealth Network. It is a program run with the University of Wyoming that provides essentially free Zoom licenses to healthcare providers that provide telehealth services. Prior to the pandemic, about 2/3 of the registered users were mental health or substance use disorder providers. So mental health was already a little bit farther along in this field prior to the pandemic. And then March came along, and frankly, the field exploded for a number of reasons. Some of it was just, as you can imagine, people not wanting to go in person to receive services. A lot of providers wanted to keep those services open and available to their patients, and they did so via telehealth. For my centers, during 2020, we had a couple of centers that, due to public health guidance, were able to kind of turn on a dime and essentially move to offering nearly 100% of their outpatient services via telehealth. It's been a good year for telehealth. We've found a couple of interesting things. First of all, our no-show rate for telehealth appointments is far below what our no-show rate is for in-person visits. It seems like our clients are willing to kind of jump on for their appointments, whether they're in their car or kind of running around the house, or it seems to have reduced a barrier. We have a number of clients that prefer telehealth. Some of them that have issues leaving their home or access issues in terms of trying to get actually to one of our centers to see an in-person provider. So telehealth has really managed to lower those barriers, and it's been quite mainstreamed. You can attend a telehealth appointment with one of our providers. Most of our providers use Zoom. Apologize. Most of our providers use Zoom, but there are also other platforms that are very easy to use. You're not required to download any special software. A lot of times you can get an email link sent to you, and you can click on that via a mobile device or a tablet or a laptop, and it'll take you into whatever platform that provider is using for providing that telehealth service. I will say very honestly, telehealth is not the panacea. It's talked a lot about in terms of solving a lot of rural healthcare access issues. So places that may be isolated during these winter months that we're having when we get those lovely snowstorms, really rural or frontier areas of the state where they don't maybe have a provider located directly in a small town and there's travel involved. It is a very important tool in the toolbox. And we've tested that over the last 12 months and really found that to be the case. It's an incredibly important line of service to be able to get service into to these clients that can't leave their homes for whatever reason, or they have such a busy schedule that a telehealth appointment works better for them in terms of mental health. I want to touch just a little bit. I think I'll leave it to Mr. Hackman and Ms. Simino, who are actual providers, to talk about efficacy. But we have found just in general practice that it is an effective form of treatment. It does achieve outcomes that are outlined in terms of receiving mental health treatment. And that has been backed up by numerous studies by CMS, which is the Center for Medicaid and Medicare Services from the federal government. And so we don't have any concerns there. Again, it's not a panacea. There are still clients that want to be seen in person. And certainly providers want to be able to provide in-person care as well. We're not suggesting in any way that we would completely change to telehealth. And I should clarify, the centers that had to go telehealth earlier during the pandemic have now been able to, with various PPE and other things, transition and reopen to offering those in-person services. But again, we're still seeing a number of clients that prefer to attend via telehealth. During the last year, we've seen a couple of kind of important things that have helped propel this concept forward. And committee members, I would draw your attention to an email that I sent you guys yesterday. It has 2 executive orders in it from President Trump that were signed in 2020, one in August and one in October. And so I would draw your attention first to the August executive order. This order was specific, kind of directing more investment and moving forward on telehealth access, specifically to rural healthcare. It specifically talks about improving communications infrastructure in Section 3. We have seen those movements forward. There are numerous federal agencies right now that are offering programs to support broadband infrastructure, both through the FCC, which is the Federal Communications Commission, or HHS, which is the Health and Human Services Agency, and a number of others. So I thought that's a pretty good kind of overview of where we've seen from a federal point of view where things have gone. The order, and including in the October order, also talks about the need for CMS to continue to make those changes that they made during the pandemic to allow for payment of telehealth services more permanent. And we have seen CMS do that. They do reimburse for all of those types of visits now. And again, like I said, there's quite a bit of usage there. Just a note on some activity that for 2020 from the Wyoming Telehealth Network. Their data shows that for the providers that were using a Zoom license through them, which is not everybody. In fact, we don't know quite what slice of the pie that is. But for the providers that were using, mental health providers that were using a Zoom license through the telehealth network, there was about 400,000 hours of service delivered on those licenses directly to clients in our state. I would say about probably 125,000 of those were specifically mental health hours. So as you can see, that's a pretty significant number of hours of service. And although we are all waiting with bated breath for the end of the pandemic, we suspect that the request from our clients for telehealth will continue to move forward in the future. And so we want to make sure that this parity bill, really what it does is it brings the requirement in to help us comply with the Mental Health Parity Act in terms of providing coverage, but it also ensures that those providers receive payment for that service. And the last piece that I'll touch on, because it's come up before, is just that there's this question lingering out there about why we would want payment at the same level as an in-person visit. And the answer is pretty simple, and it is because the costs do not really vary, whether it is an in-person visit or a telehealth visit. For mental health professionals and for our centers, the costs of providing that service are primarily based in the provider's salary and benefits. There is minimal cost for overhead, such as for a building or an office. But when you compare that to having to have very good internet service, appropriate telehealth equipment, laptops that are up to date, all of those things. And then you add on the addition, when somebody is coming in for a telehealth visit, we still have to acquire the necessary paperwork, either through a software portal that is paid for by the providers, or some of our clients still want to do that by snail mail. So there's exchanging of paperwork by snail mail for authorizations and insurance and that type of stuff. So those costs really do not change whether it's in person or via telehealth. So, Mr. Chairman, I know that was a lot of information, and I know I have a lot of other colleagues here that would like to add some comments. So I'm going to stop there and stand for questions.
Thank you very much, Ms. Somerville. I see a question up there in the corner. Senator Furphy, go ahead.
Thank you, Mr. Chairman. Mr. Somerville, are providers currently receiving less payment if they submit for remote versus in person?
Ms. Somerville?
Mr. Chairman, Senator Furphy, in general, during the last 10 months, no, I do not believe so. But what we have seen is a number of, especially insurance companies across the board, they've kind of continuously extended their temporary orders for allowing telehealth or their payment numbers. And so we are concerned about the future because this has been brought up in conversation, like I described before, in terms of what type of payment they should be providing for that coverage. And so we want to support this bill to make sure that we keep that level so that we can keep providers interested in providing telehealth access and keeping that going. If they receive a lesser payment, it's certainly a disincentive to a provider or a center to continue to offer that service, given the ongoing cost of software and things along those lines. And I guess, Senator, I would also add, it's a mixed bag with insurance companies generally when you're dealing with benefits, but I would let my colleagues, Mr. Hackman or Ms. Simoneau or Ms. Folan, talk a little bit more about insurance, as I believe all three of them have directly billed in the past.
Thank you. Any further questions, committee, of Ms. Somerville? Seeing none, I thank you for the term snail mail. I haven't heard that for a while. I suspect that will be a trivia question less than 10 years from now on some game show. On maybe television, if we still have television, we may not have that in 10 years.
Mr. Chairman, I belie my age, so I apologize.
Thank you, Ms. Somerville. We did not discuss age in this committee. Let's move on. Let's hear from the providers here, if we would. Mr. Hackman, if you would go ahead and step forward and share some testimony with us.
Thank you, Mr. Chairman. Good morning, Mr. Chairman and members of the committee. Dr. Hollis Hackman. I'm a psychologist. I'm representing the Wyoming Psychological Association. And my association, which represents many of the private providers and other psychologists in the state, stand in support of this bill. Personally, I've been providing telehealth services since the 90s. I did my career with the VA, and the federal government tends to break ground in some of these areas because we have to be the mothers of invention. We've got veterans all over the country, and reaching those veterans and getting services to them has been vitally important for the VA for years. So going further back than that, my alma mater, the University of Nebraska, really pioneered telehealth work back in the 50s with a link up between the University of Nebraska and the VA in Omaha. So having said that, the last 8 years of my career with the VA, which just ended recently, was exclusively telehealth work. My specialty is treating post-traumatic stress disorder, which is common amongst our combat veterans, and using a specific technique called cognitive processing therapy. And I won't get into the details of that, but I worked with veteran after veteran via telehealth and had very good outcomes. In fact, the outcomes from using my treatment approach with telehealth were as good as they were for in-person types of encounters. And part of that is because, as Ms. Somerville mentioned earlier, some patients really prefer a telehealth kind of a platform. In my case, working with PTSD guys, they tend to be kind of socially isolated and have some problems with emotional numbing and things like that anyway. So they really find the distance that's kind of built in between the provider and the patient. They find that helpful to them, and they're more able to focus on the issues that are creating problems for them in their lives. So telehealth, and as far as I know, I'm not aware of any study that shows that telehealth is any less effective than in-person in terms of efficacy and outcomes. I'd like to hear the reference if there is one. And there are studies after study that show that it is equally efficacious. So I just wanted to mention a couple other things. I asked recently the American Psychological Association about what's going on nationally with these kinds of requirements of insurance companies. And the majority of states, that's 42 plus DC, have some kind of mental health coverage mandate. So we're one of the few states that don't have something on the books. And that's concerning. I understand that under the current CARES Act, there are requirements for insurance companies to cover these kinds of services. But as Ms. Somerville mentioned, those things will be timed out at some point. So we have concerns that safety net will go away. And we certainly don't want to see that. The patients that we serve don't want to see that. They want to be able to continue to get these services regardless of where they live and for their convenience. So I think those are the main points I wanted to talk about. But I'm happy to stand for any questions, Mr. Chairman.
Thank you, Dr. Hackman. Committee, have any questions for Dr. Hackman? No, everybody did not have enough caffeine this morning.
Thank
you very much for your presentation. Before we go to the next presenter, I would make the committee aware that here in the next roughly 20 minutes or so, Senator Anderson is going to be sworn in the chamber where at least 3 of our members are sitting, and we may take a short break of about 10 minutes there so they can participate in that swearing in and observe it. But it'll be a short break, an important one. We welcome Senator Anderson back. We welcome back Chairman Anderson. So with that in mind, thank you, Dr. Hackman. We will move on to perhaps Ms. Foland. Would you mind giving us a testimony and sharing your thoughts with us this morning? Welcome to committee.
Thank you, Mr. Chairman. Mr. Chairman, members of the committee, thank you for the opportunity to speak today. My name is Cheryl Foland. I'm an LCSW, licensed clinical social worker in Rawlins. I'm in independent private practice, and I'm also the legislative advocate for the Wyoming Association of Addictions Professionals. One of the things that I cannot stress enough is that Dr. Hackman and Ms. Somerville are absolutely correct in the efficacy of telehealth, whether it be by telephone or by video. There's a study from 2018 that actually looked at 32 different studies on the efficacy of mental health telehealth and severe mental health illness. And what the authors found, and it was Luz Wickman and McBain, what they found was there was absolutely more positive things that came out of mental health telehealth than the negative. We have advanced the broadband network, which was one of the big identifiers of challenges across the United States. Of course, Wyoming, it is one of our big challenges. The other thing that I have personally seen in my practice, as Ms. Somerville had stated, was my no-show rates decreased by 25% in the past year. And I've been using telehealth, probably off and on for about almost 20 years now. And I started my career with the VA in Wichita, Kansas, and have continued to serve veterans across the United States. Being in Rawlins is also a challenge in the winter months, where last in 2019, I had no-show rates of almost 35% in the winter months when I-80 and 287 were shut down and no one could get in or out of Rawlins. And I treat people in Sweetwater County, Natrona County, Albany County. So if they can't get onto I-80, I'm not going to see them. I do a lot of family therapy and a lot of work with children. And this has opened up my ability to help and provide services for an entirely different group of people because of the telehealth access that is required under the CARES Act and the executive orders by former President Trump. With that being said, our organization absolutely supports this bill. I support it, and my private practice colleagues here in town also support this bill. As to Senator Furphy's question earlier about costs, I did find, as I went back through some of my billing, many of the insurance companies that I work with do in fact provide, I would say there's a discount. They pay less, they reimburse less for telehealth services than they do for face-to-face services. And in fact, some services are not even reimbursed at all. So I'm doing it pro bono at no cost to the families. The concern that my organization has, the providers that we have, and my own personal ability to provide services, once the CARES Act monies end, and hopefully we go back to whatever our normal is going to be, I won't be reimbursed if insurance companies are able to go back to pre-COVID requirements. And that, for my part, is unacceptable. And what I will find is I will not accept those insurances to provide those services because I can't afford to do business if I'm not being reimbursed. I still have to pay my internet. I have to pay for my phone. I have my overhead. And I'm in private practice by myself. So revenue is a consideration. I have contacted the medical professionals in town who have been providing mental health, or physical health services via telehealth. And they have seen no increase or decrease in their funding and reimbursements by insurance companies. So they're still being paid the same as they were prior to the COVID pandemic. So kind of a lot of information at once, but I do stand for questions.
Thank you, Ms. Follen. Committee members, any questions for Ms. Follen? Senator Furphy, go ahead.
Thank you, Mr. Chairman. Ms. Follen, are you finding that you mentioned this broadband situation? Are you finding many patients that still do not have access to broadband and thus cannot access telehealth?
Ms. Follen, go ahead.
Mr. Chairman, Senator Furphy, unfortunately, yes. Bear Oil is a prime example. I have some folks out there and in Jeffrey City that actually have to drive to where they can receive a signal for their cell phone to be able to receive those services, because broadband is still a huge problem in a lot of these remote areas between Jeffrey City and Lander. I have some folks out there that actually have to drive over to the rest area so they're high enough up to receive a signal. So unfortunately, yeah, and Elk Mountain encampment still have challenges as well. So unfortunately, yes, broadband is still a problem.
Further questions, committee? I see none. Thank you very much for your testimony, Ms. Fullen, and again, welcome. For all those who are more east in the state than I am, the snow is coming. Winter's on the way back. It's here. It's on its way to you.
Thank you
very
Mr.
much.
Chair.
Thank you very much. Ms. Somerville, go ahead. You have a comment.
Mr. Chairman, I apologize. Actually, she just got in. I just wanted to let you know that Canyon Hardesty from the Wyoming Telehealth Network was in the waiting room wanting to get into the meeting.
Very good. I see her smiling face. Let's go ahead to Ms. Semino, if we would, please. All right. There's her smiling face. Go ahead, Ms. Semino.
Mr. Chairman, members of the committee, my name is Lindsay Semino and I represent the Wyoming Counseling Association. We are in support of this bill. When COVID first started, what we saw was that initial denial for telehealth services. Granted, that was because nobody in the United States knew what we were looking at and what this global pandemic looked long term. Within the first 2 weeks of the global pandemic, we did see that those insurance companies were willing to initially pass emergency protocols so that we could bill for those telehealth and those telephone services. Those emergency protocols were for a 3-month basis. As this emergency has gone on, they've expanded that on a 3-month basis. And so we're coming up on 1 year, and we suspect that will continue to be passed 3 months on and on until we finally have this resolved. As my colleagues have mentioned, what we are hoping with this bill is to try to make that permanent. Some of the negative talking points that we have heard, or some counterpoints that we've heard, is that this is going to be a coding issue for insurance companies. Over the last year, we've not seen that be a coding issue. When we as providers submit our insurance claims, we code it the exact same as an insurance appointment. The thing that changes on the insurance claim is we change the location. We change it from an in-person appointment or a main office appointment to a telehealth appointment or a telephone appointment. That is how we make that distinction. We also make the distinction within the note so that if insurance companies want to audit us, if they want to see how that service was provided, they can see that as well if they want to ask for the clinical note and have that detailed information as well. So as far as a coding issue, we have not seen any specific codings for telehealth, and so we are not billing it differently. So we do not see the coding issue. And when I talk to my insurance panels that I interact with, they are not experiencing a coding issue either. This bill really does honor these executive orders from President Trump. If you look at the one from August 3rd on Section 5, the title for Section 5 is expanding the flexibilities beyond the public health emergency. And that's really what the heart of this bill is trying to do. We have taken what the insurance companies have done for this public health emergency, and what we're trying to do is now make this telehealth provision long-term and expand it, especially for this rural area that is so plagued with a mental health crisis and with suicidality. As Ms. Fullen touched on, what we are seeing is that we do have an infrastructure issue within the state of Wyoming. Not everybody does have access to broadband. And so that is one of the reasons why we advocated, and we have language within the bill for telephone services as well, so that those who do not have access to broadband, or who do not have the capacity to work broadband or work Zoom, still have the ability to have access through telephone services and have that covered as well. This, the point I would like to drive home is that this really allows the client to choose their provider within the state of Wyoming, regardless of circumstance, whether it is a global health crisis, whether it's winter, whether it is a lack of broadband, and it also allows them to get the coverage that they deserve from their insurance policies. And with that, I stand for question.
Thank you very much, Ms. Semino. Are there any questions, committee members? One note that I would make, committee members, is that, and Ms. Semino touched on it, is we talk about audio visual in the bill, and we may want to make an adjustment when we work the bill to include just plain audio, as well as audio visual. And I know I'm stealing words from Mr. Laycock's mouth there, but that way he won't talk as long. But there is a question. Some of these are being done by telephone only and do not have the broadband or the internet capacity to do telehealth or do the visual part of it. So audio is a piece of this too. There are visits being done by audio only. So that's something we'll talk about when we work the bill. Any questions for Ms. Semino? Seeing none, let's move to Ms. Curran. Ms. Curran, I see you're anxious to speak to us. You're not smiling. Oh, there you're smiling. Go ahead, Ms. Curran.
Good morning, Mr. Chairman, members of the committee. Am I still muted?
No, you're not. Go ahead.
Oh, okay. Thank you. I'm Wendy Curran. I represent Blue Cross Blue Shield of Wyoming, and I have visited with several people who have spoken before me about this. And I will tell you, it is very difficult in Wyoming sometimes to be the insurance company that tries to be a good neighbor and insures most of the people in the state, the majority, I mean, the largest block, and to try to defend insurance companies who may act entirely differently than we do. So I'd like to just say that Blue Cross Blue Shield absolutely agrees with the concept of telemedicine. We have been reimbursing for telemedicine visits since the late 90s, I think, both on the medical physician side and for mental health. We believe it is effective. We believe it is critically important in the state for all the reasons that we've mentioned, for travel, for patient choice, for the ability to continue treatment and not have any no-shows. We support that. And we have for years, without any legislation or regulatory directive, reimbursed at parity for a audiovisual visit, telemedicine, and an office visit in person, face-to-face. We have done that for years, and that won't change. We believe that that's important, and it supports the system that we're trying to build. We do, I think there is a large misunderstanding between audiovisual, which most of us commonly call telemedicine, and audio only. And before the pandemic, we did not reimburse. Very few insurance companies, including CMS, reimbursed for a telephone call, an audio only visit. That changed in the pandemic when it became apparent that that was the only way that practitioners and patients were going to be able to maintain connected, was through the audio only phone call. We now reimburse for audio only visits. They may be coded as telemedicine, they may be coded as audio visual. There are some provisions that if you are providing a service by telephone only, that there's a different way to bill for those. There's a different code. And that code says, I'm doing this service and I'm on the phone with Mrs. Smith for 25 minutes. And I'm on the phone with Mr. Jones for 45 minutes. And it's the length of time that the telephone visit takes that constitutes how you would reimburse for purely only a telephone visit. We're not seeing many of those codes come in, and this applies for medical practices, for therapist practices, for mental health, behavioral health practices across the board. We know that people are having to make contact by audio and will continue through. I think nothing will change in our reimbursement for a telemedicine visit and an office visit. Those provisions are already covered in the federal law, the MPIA, if you will, which I can't exactly remember what that all stands for. But that is very, very clear that insurance companies cannot, under federal law, charge differently, pay differently for mental health services, put more restrictions on mental health services, limit the number of visits any more than they do for services on the medical side. Very clear. That's parity. That is mental health parity. It's the law of the land. It's pretty clear. Blue Cross Blue Shield right now is undergoing an audit by CMS to make sure that we are in compliance with mental health parity. So this is really not parity between services or somehow failing to pay an equal amount for certain services. I think that that's important to note when we're talking about telehealth. Most of the visits that we've seen and the increase that we've seen has been in true telehealth, not audio only. So when the public health emergency goes away, it won't mean any changes to what we have been doing. The only question is, would we, just like CMS is considering, continue to reimburse for audio only services? And because that's a new area for us, for everything, I believe that people say that it's effective. I also know that we have had many providers tell us that while it is not the panacea, it's important to have, and that a face-to-face, not a face-to-face, but a visual connection with your patient is much better for the treatment and the care. So we really don't understand what this bill does in terms of equalizing payments or assuring payments. What it seems to us to do is to simply say, you must pay the same for service A as you pay for service B, and telemedicine or in face-to-face or audio. And it's not something that we see as a problem. We think most of it is already provided under the federal law, and we do not believe it is the place of this body to say, you must pay, you must charge, this must cost the exact same for this service delivered this way as it does for anyone else. I'm not sure that that offers any more protections to anyone, and it is simply a mandate that says this is what you have to pay. We don't care whether you can work out a suitable care program with some providers, and in turn for certain things they will want to say, we can give you a better price. It doesn't allow for anything that might be in the competitive interests of both the providers and the commercial insurers. I think it is simply a mandate that addresses a very narrow piece of the healthcare delivery system, offers, I guess, some protection, if that's the term, from other insurance companies, that no matter what, these services will always pay the same.
Mr. Chairman, I hate to interrupt, but we have everyone in the chamber now. Could we take a little break now and come back? I do have questions.
We can, Ms. Coran. Would you mind if we just held on to you? Keep your thoughts in your head, and we will break here shortly. Committee will stand at ease for about 5 to 10 minutes, please.
Thank you.
Carly, you probably want to change that to AM instead of PM.
Mr. Chairman, we're gonna allow you guys to see the ceremony as well, okay?
That's a great plan.
Yay.
Very good. Tell Senator Anderson to talk loudly.
See Senator.
At least we shortened it. Oh, Mr. Vice President. But it was about 10 years ago we shortened it.
Ellen? Yep, you're in the, okay, there you go. Thank you, ma'am.
Make it bite-sized. Get your darn hand up in there. Who's this Fidelity you're going to be with?
We can get the committee to come back on here. Very nice to have Senator Anderson, Chairman Anderson back with us. It doesn't look like he's changed a bit since I saw him last.
Thank you, Mr. Chairman. We appreciate that.
Okay, Carlo, I think we're ready to go back in. The committee will come back to order and we'll go back to Ms. Curran. If you'd like to finalize your comments or throw anything in that you forgot, go ahead and talk to us and then we'll ask you questions.
Thank you, Mr. Chairman, members of the committee. I hope I haven't lost my train of thought completely, but I do want to conclude by saying I think that this measure is really trying to prevent something that hasn't happened yet and may not happen yet. As a matter of fact, there is a provision in the Consolidated Appropriation Act, which, you know, Congress passed in the dark of the night on December 31st, that has so many provisions for healthcare that it is astounding. One of those says that bill, that federal law, expands access to mental health services in Medicare through telehealth, including from the beneficiary's home, beyond the end of the COVID-19 pandemic and public health emergency. So that is already in place. That already now is a federal law. And if it is adopted by Medicare and Medicaid, then all other insurance companies will likely follow suit, particularly having to make sure that we are in compliance and parity with federal law. I would also say that this area is changing dramatically across the nation, as we've seen. I'm not sure where things will end up, but I know that Blue Cross Blue Shield of Wyoming will keep in place those things that provide better patient care and better access to providers. I don't think this is a universal problem across the system. I think there are some who do and some that don't. And I'm not sure that passing a regulatory mandate that falls into the mandate section of the insurance code that directs any commercial insurance as to what they will or won't pay is the answer that everyone on this call is looking for, to make sure that we are allowing and promoting telehealth services. With that, I'll stand for questions.
Thank you, Ms. Curran. Questions for Ms. Curran, committee? Senator Bouchard.
Thank you, Mr. Chairman. I saw articles that basically said that health providers were reducing the cost. So, I mean, and I'm not saying that your company did, but I certainly did see articles that had that take place. So, I mean, isn't that kind of what we're doing here? We're making sure that we're putting a safeguard in place so that it doesn't happen.
Mr. Chairman, Senator Bouchard.
Go ahead.
Yes, I suppose. I think that the pandemic has changed the discussion, has changed the landscape. I know that other large national for-profit insurance companies often paid telemedicine at 80% of an office visit or 50% or something else. I have seen those change under the pandemic. We, of course, did not do that. I'm not sure. I do know that a blanket regulatory mandate intended to address a few bad apples might not provide what the supporters believe it will do. Mandates do not save costs in the healthcare system. They tend to overall increase costs. I'm afraid that if we do this, we will be in conflict with the ever-evolving federal scene. And I won't be surprised if the legislation that's present in the Consolidated Appropriation Act won't be expanded as we go forward under the new administration as well.
Thank you. Follow up, Senator Bouchard.
Thank you, Mr. Chairman. So where I have a problem with is, I mean, I know that insurance companies are always trying to reduce the costs, and I get it because there is an issue there where the whole insurance factor. But that said, I think that doctors have to, and healthcare providers have to make a decision sometimes when they decide to make either a phone call or use visual aids. And I would assume that even their malpractice goes up on some of those things. So I mean, I don't think their costs go down when they're maybe at a convenience level for someone that can contact the doctor because or a provider that they're in need. So with that said, what is the harm here if we just say that it's not, we're going to charge the same on either side? If I'm hearing that you're saying we haven't had a problem with this, then why is this a problem to put it in place? So give me I want to hear the one reason why we shouldn't do this, if you have one.
Ms. Grant.
Mr. Chairman, Senator Bouchard, I think that one reason is that the federal regulations for MPIA are very clear that you must pay equally, equitably, fairly between services that are provided on the medical surgical side and the behavioral health side. If this mandate goes into place that says commercial insurance, you must pay this rate for these things always, I'm afraid that we end up being in the adverse position of, rather than complying with mental health parity, having the mental health side with more protections and more locked in costs than we do on the other side. I don't think that this bill accomplishes anything that isn't already provided for or might continue to be provided for. And I think it is simply an over-regulatory reaction to a problem that may not exist in the future.
Thank you. Further questions, committee? Senator Furphy.
Thank you, Mr. Chairman. Ms. Karen, good to see you, by the way. Thank you for coming here and testifying. And I want to compliment Blue Cross Blue Shield. You do a wonderful job for our state, and so thank you. But my point, following up on what Senator Bouchard said, you're right. This bill does not impact you. and your company, you're doing all the right things. But as you indicated, there are some bad apples out there. And that's what we're trying to get to, those who cut those costs to the providers. So once again, if we pass this bill, it doesn't seem like it's going to affect you at all. But if we can get to the bad actors, so once again, I'll ask for your comments on that issue. That's what we're trying to do. Thank you.
Thank you, Senator Furphy. Ms. Curran.
Mr. Chairman, Senator Furphy. I think that what this does is simply create a position in which there are certain protections for certain healthcare services by a certain set of providers that are not equal across the healthcare system. I think it diminishes competition between the private sector providers and insurance. It disincentivizes the ability for us to work to use costs that are appropriate. As I said, there are differences between what CMS allows and what is coded. It probably won't change what we do, but it does take away a number of tools from us and our ability to work with providers to say, are there lower cost ways to do this? I agree that there are overhead costs no matter what the situation. Unless you get the guy in the back of a car with his computer and his cell phone treating patients because they just signed up with him on the website. I mean, I don't think that's going to happen, but were that the case, we would be required to pay for it just like anything else. So I just think that this is not the route to go or the section of the statutes to put it in.
Thank you, Ms. Curran. Senator McEwen, I like the screen hand. I like that a lot. Go ahead.
I do too. Can you hear me, Mr. Chairman?
I've done it.
Yes, sir. Go ahead, Senator.
Couple comments. First, nothing in this bill raises the cost of healthcare with NPA, AI, or any of that. All it does is say that telehealth should be paid as if you were there. And I'm going to throw this out too, which might sound a little crazy, but if I'm a doctor in back of my car with a cell phone and a laptop, and I provide the same service I do in an office, you are now taking my ability to be competitive away from me for the benefit of the insurance company. This bill doesn't affect anything at all. I haven't heard an answer onto why we shouldn't support this. Thank you, sir.
Thanks, Senator McEwen. Ms. Curran.
Mr. Chairman, Senator McEwen, I'm sorry, my reference was simply not to the competitive nature, but to the patient safety and the practicing within the scope and sort of the things that go along with the medical treatment, not any competitive issue. One of the things that I will point out again is that parts of this bill talk about audio. Most of the bill talks about audio visual. I think that audio is a separate service. And right now we pay the same for an audio call made by Lindsay in her office as we would pay for an audio call made by Dr. Hallinan in his office. That's where the parity comes in. That's what we have to do. Were we to say we will never reimburse anyone for an audio call, I think in the current environment and under the pandemic and everything that we are learning, that's very, very unlikely.
Follow up, Senator McEwen.
And I understand that, but I'm going to go back to this. If we're going to support telehealth, which I think we should, I don't think being in an office, an attic, a rooftop, the back of a car changes the mental process of the healthcare provider. The location doesn't change anything. And it seems to me that we're focused on, oh, you should pay more because he's maintaining brick and mortar. We almost need to turn this back to a little more into the free market, because like I said, I don't think it matters whether he's in a car, a roof, or an office. If this is, as everybody said, a viable solution, location has little or nothing to do with it and doesn't change the quality of the care. Thank you.
Senator, comment, Ms. Curran?
Mr. Chairman, Senator McCowan, I am only reflecting how today's U.S. health system is set up, and those are set up that the CMS has a panel. They determine what a code, what a particular service is valued at, and they do take into consideration the kind of treatment you're offering, where the service is located, all those complicating factors, and they develop codes. And those codes are what most providers use, all providers use to pay. So I'm not saying it's a good system. I'm not defending it. I am just saying that is the relative value of something that's done by phone generally has a lower value and a lower payment. I'm not defending it. I'm just saying, unfortunately, that's what we have.
Thank you very much. We'll go back for one final follow-up from Senator McEwen, reminding the committee that the end of the meeting is in sight, the light at the end of the tunnel. I don't want to get run over. I want to make sure we get this bill out. So go ahead, Senator McEwen.
Yes, Mr. Chairman, just one last comment. I don't believe this bill infringes upon anything of what you've just said. So I think I support the bill. Thank you.
Thank you, Senator McEwen. Let's go to Senator Bouchard, please.
Thank you, Mr. Chairman. I did want to chime in on the comment about how they're already billing on parity. I don't see why this bill would be a problem then. And I'm also concerned that there are other plans that are outside of the realm of Blue Cross, maybe a company plan or something that isn't regulated the same way. And I think I'm not sure Blue Cross can speak as to how that works. And so that's where I'm really concerned. We want to make sure that the playing field is equal everywhere, not just with maybe one stakeholder here. So I'm going to support the bill as well.
Thank you, Senator Bouchard. Any comments, Ms. Grant?
No, thank you.
Go ahead, Senator Hutchings, before we move to the final two presenters.
I'll try to be quick, Mr. Chairman. This is to Mrs. Curran. Basically, what I'm hearing you say is the federal government has already passed the law. Usually, once the federal government has passed the law, insurance companies will kind of flow into compliance with what the federal law says, and that this particular proposed bill, what it's doing is kind of, we're putting the cart before the horse. Let's slow down. Let's wait a little bit to see what happens and how this whole thing will work out. You guys are already doing, Blue Cross Blue Shield, what they want, but other companies aren't. And your desire is not to have us regulate what everybody else is going to do just yet. Is that what I'm hearing?
Mr. Chairman,
Go ahead.
Senator Hutchings, that is indeed correct. This area has been a changing field since the early days of the pandemic. It has created changes in where we get care and how we get it. As I told you from the Consolidated Appropriations Act, some of that is all being put into law. Other considerations are still under consideration, discussion, and I think that before we are done, we will have clear standards for national coverage of telemedicine and audio.
Thank you, Mr. Chairman.
Thank you, Ms. Green. Let's move on to a couple of final presenters here, and then we will move the bill into committee for consideration. Mr. Laycock has been very patiently waiting. He's in the corner right now, but go ahead, Mr. Laycock, introduce yourself and share your message.
Thank you, Mr. Chairman, committee. My name is Tom Laycock. I'm the Associate State Director for AARP Wyoming, and because time's getting a little bit short, I'll move down on a few things that I'd had to mention. I just wanted to let you know AARP Wyoming is very supportive of the bill. We think it does keep open access to mental health and substance use counseling through video and telephonic delivery models. Part of the reason we think that's important is this last year in the summer, AARP surveyed Wyomingites age 45 and over, and 78% of them have said that they are using or willing to use telehealth. Now that's great. However, 22% said that they had no interest in using telehealth through a computer or tablet at all for any number of reasons between lack of a strong internet, cost, technical expertise, or maybe they just preferred using a telephone. So we do appreciate the fact that this bill does discuss some availability for audio only. We're aware that some insurance carriers, such as Medicare and others, have loosened restrictions on payment of services delivered via telehealth or phone. We hope that continues, and our conversations with staff from our federal delegation lead us to believe that won't change anytime soon. We see the change to allowing services via telehealth and telephone as one weapon against fighting depression, substance abuse, and the state's suicide rates, which really skyrocket after the age of 70. It's kind of a huge deal for us. So I had quite a bit more to say. I kind of see where you guys are going, and I'm happy to stand for questions. I did want to answer one question Senator Furphy had mentioned about, do you still have folks who are lacking internet or the ability to get internet? We actually got something yesterday on our survey that suggested about 2,500 of our members have suggested that they didn't have access to internet. Now that could be their lack of understanding for what exists, or very possible that they don't have access. We're trying to change some of that, just in terms of letting our members know what's out there, in terms of things like Project Lifeline that allow for a lower cost internet service hookup for our states age 50 and over. But the takeaway is, for us, we appreciate the coverage parity, the ability to get online, the choice and the independence that offers, as well as the ability to get telehealth services via telephone. So I'll stand for questions and get out of your hair.
Thank you. Any questions, committee members? Appreciate that. I see two more faces there that haven't had a chance to talk to us, and my screen keeps moving. You people are moving all over my screen. It's very confusing. It's making me dizzy. Ms. Hardesty, you've been very patient. Would you like to speak to us? I'm sorry, you're coming through terrible. We can't understand a word you're saying. Still not. We'll see if you can get that corrected. In the meantime, Ms. Burke, would you like to speak to us?
Thank you, Senator Baldwin and committee. Denise Burke, Wyoming Department of Insurance. And you may have noted we've remained rather quiet on this particular bill. I'm not speaking for or against it, but I chose to join in to maybe clarify a couple of things. First of all, just a reminder that the Wyoming Department of Insurance does not have the authority for rate setting. And secondly, we are what is called a direct enforcement state. In other words, we agree that we will have the provisions of the Affordable Care Act, but the enforcement of those provisions come from the federal level, from the Center for Medicare and Medicaid Services. So I think that Senator Hutchings' comments about perhaps it being a little bit premature because of COVID-19 and the pandemic and all of the things that have transpired because of the executive order and what is happening with mental health treatment. The bottom line, if I may be so simplifying of the bill, is that this is really addressing payment parity and not service parity. And I think we are going to indeed see additional guidance from the feds saying, this is how the new world is going to be handling mental health treatment. And so the apprehension, and again, I'm not speaking for or against the bill, but my apprehension is that we don't want to get ourselves into a position where we have said, this is a go ahead, everything is fine and great and wonderful, and then be left holding the bag on a mandated service when the intent of the bill was for the payment parity. And so while it seems like a very minor change to go from telehealth parity to including straight audio, I don't think that the feds have caught up with that yet. And we could inadvertently be left with a situation where we are being told the state has mandated this, so state, you get to pay for it. And I don't think that that's what will ultimately happen, but I don't have a reassurance that it won't. And so I'm just a little bit apprehensive to go full bore for or against it without knowing where the feds are going to go with this. The indications are that they are indeed going to authorize this, the act that Ms. Curran referenced, as well as some additional guidance that has come out. And I apologize for getting down into the weeds on this, but the feds have really spent a lot of time and effort trying to define different ways that services are being provided and categorizing these into two broad categories. And again, I apologize for really getting into the weeds, and I'd be happy to answer questions offline, but really looking at what services for mental health are what are called NQTL, non-qualified treatment levels, and what are QTLs, qualified treatment. And while I think the majority of our insurers are really trying to comply with that, to be honest, there's confusion. And it leaves the department in an awkward position. It leaves the providers in an awkward position. And all of us saying, all we want is to get good care for our Wyoming people. But we don't want to do anything that inadvertently gets us before the actions by the feds. And if we were not a direct enforcement state where we actually could take these actions by the department, perhaps we would have a different stance on it. But we are in a little bit of we need to just be a little patient. And because we know, I really appreciate the comments from Andy and all of the others about the effectiveness. I don't think anyone's going to disagree with that. And because of the pandemic, we have been able to dramatically increase services to our Wyoming people. But the concern is how that's going to be paid for. And in these tough economic times, we don't want to act in such a way that we as a state, our providers and our insurers are left holding the bag for something that it appears the feds are going to give more guidance on. I hope that maybe muddied the water, but I hope it clarified some things as well.
Thank you very much for the enlightenment, Ms. Burke. Question, Senator Hutchings.
Thank you, Mr. Chairman. Quick question to Ms. Burke. Can you provide for us, maybe via email, information on direct enforcement state? Can you do that? Thank you.
Senator Baldwin, Senator Hutchings, yes, I'd be happy to do that. If I could just briefly explain what that it says is that the states that are direct enforcement, and by the way, there are only 3 remaining, and that is Wyoming, Oklahoma, and Texas. We are the 3 states that say, we don't really have the manpower to enforce everything. And so we say, we will work with the feds in enforcing the provisions, but we don't independently enforce them. And so, for example, Ms. Curran talked about the Mental Health Parity and Addiction Equity Act. The common term is MAPIA. We are fully aware of it, and we look to see that our insurers are complying with that. But if it came to an enforcement of that, we would talk to CMS and say, we will work with you, but because we don't have the enforcement authority individually, we will have to work with you, but not do it on our own. But Senator Hutchings, I'd be happy to send you that site.
I'm sorry, everything I said. I'll say it again. Any further questions, committee? The mute button is quite touchy today. Senator McKeown, go ahead.
Thank you, Mr. Chairman. You made the comment that the state's going to end up paying the difference on this, possibly. Is that paying for the difference on this by not receiving federal funds, or are we actually going to send checks to insurance companies? I'm kind of new to this, and when you say pay for something, I want to know how we're paying, ma'am.
Ms. Burke, go ahead.
Senator Baldwin, Senator McEwen, I empathize. It is a very complex system, so no criticism there. The mandate issue becomes very confusing. In short, the federal government, and this is a real simplification, so I apologize for that. But in short, the services that are required to be covered under the Affordable Care Act, the 10 essential health benefits, if there are things that go above and beyond those coverages that the state mandates must be covered, then there is not reimbursement from the feds for those additional coverages. So most everyone is aware of, for example, an inadvertent step that we took a number of years ago regarding supplemental nutrition for certain identified conditions, particularly in children. That became a mandated coverage in Wyoming. Because that is not expressly under the Affordable Care Act, then the state is responsible for that, and it's not part of the federal reimbursement. Hope I explained that so you follow me.
I think I understand, and I appreciate the simple answer. Basically, if we pass this, we may be foregoing federal funding or some form of federal funding.
Ms. Burke with one finger up. Go ahead.
Senator Baldwin, Senator McEwen, I can't say that we necessarily would, and I think that's the reason the department has waited to chime in on this, because we did talk with the feds about this particular bill, but at the time, this was a number of months ago when it was first being discussed, at that time, we were not yet into COVID, and we were not, at that point, it was much more clear, and they were saying, well, this is a payment parity, and it's not a problem. But when it moves into a change in the service being provided, then it could be a problem. But we have not gotten an exact clarification from the feds on that, and partly because things are in transition. And so it may be perfectly fine. It may, if it passes through and it goes into effect, we may not have an issue. But I feel like I owe it to the committee to say, but wait, things are coming, and it could be a problem if the feds say, you've overstepped, and this is a service provision and not just a payment parity issue.
Thank you, Ms. Burke. And I would interject that it wouldn't be the first time that we've had to step back and say, oops, we messed up, we have to fix something. And we've had to do that a number of times. So it is fixable. It's certainly not desirable that we have to go back and correct something, but it's possible. And CMS, as Ms. Burke will tell you, is very difficult to predict what they're going to say and what they're going to do. We can give our best guess, and usually we're right, but not always. So with that in mind, any further questions, committee, for Ms. Burke? Okay, let's give Ms. Hardesty one more shot. You got your sound corrected?
I think so.
There you are. Go ahead.
Great. Well, thank you, Mr. Chair. Just as a brief introduction, I'm Canyon Hardesty. I'm faculty in the College of Health Sciences. My background is in public health and healthcare ethics. I'm a collaborator and currently the director of the Wyoming Telehealth Network. So we're charged with supporting statewide collaboration, interprofessional education, professional development, and research to guide the identification and implementation of evidence and best practice-based telehealth, which I think is some of the stuff we're speaking about today, is what's the evidence behind modality of service delivery. So again, I'm here to provide perspective on the current use of telemental health in Wyoming. I have a whole list of statistics overall that really is just saying there's been a significant increase in telemental health services, which I hear that is kind of a basis of knowledge. So I'll skip over that. I think, again, although we've seen an increase in use and uptake, there continues to be barriers to access. some of which include access to specialty care, which is not really something we're discussing here, but I think is something that's potentially worth another education or conversation later, but also, of course, broadband and internet connectivity, which I think directly speaks to the telephonic piece, and then equal payment. And I would argue, or at least educate, that payment for these services adhere to standards of care and ethical practices regardless of the modality. So just additionally, some perspective is mental health providers have been engaged with some research and surveys here at the university just to help provide some additional data to support some of these conversations. We're doing a couple things right now. One is to understand changes in practice. So how and who are mental health providers actually providing increased services for as a result of this. I think that might inform some of this conversation as well. And then also the application and utilization of telemental health competencies. So I think it's important to call out that telemental health professionals and mental health professionals in general have specific competencies that they have to ensure that they're implementing when they're delivering that kind of care. And mental health is one of the first disciplines to really do this. So I think when we speak about what are the standards of care, what is the modality, I think it's important to ground this in as practicing professionals and within the discipline, there are standards of care, again, regardless of where those individuals are. The second one we're really looking at is a collaboration, again, with these practicing professionals. It is close to about 1,000 mental health providers that we've been working with. We're examining intention to continue service delivery. So we might see the rules and the laws may change, but what does that actually mean in practice? And we are seeing a significant need and also willingness to continue this modality of services. Some of the preliminary results do indicate improved outcomes, improved level of comfort, actually for individuals when they're receiving care in their homes or even on their phones in off-site locations, right? If we don't have access to broadband, that telephonic is pretty critical. We're not finished analyzing those results, and I would just offer to this committee and others, just as we continue this conversation, I'd be more than happy to come back and have maybe to help inform the conversation about efficacy, efficiency, and cost. Those aren't things that are directly built into the current surveys, but I'm definitely here in all of those roles as a faculty member, as well as a collaborator, the director of the telehealth network, as well as a consumer of telehealth services, that I'd love to offer that expertise if there are additional questions as we go forward about efficacy and cost. So I have lots of other data we can sure talk about. I'd love to provide, but hopefully that's a summary of what we're doing and what some of the unanswered needs and questions are. But I think it's really important to consider when you're moving forward with this bill and others that look at service delivery. So, any questions?
Thank you, Ms. Hardesty. Thank you very much. And I would note, committee, that we will be seeing Ms. Hardesty again. I'm going to strongly recommend that in the interim, after March, that is that we will have this as an interim topic. Telehealth is evolving. Telehealth is a big deal, not just in mental health and addiction services. It's a big deal in all the health areas. I myself use it, and I'm still getting used to it, although I use it a lot. So we will be hearing more. Committee, are there any questions for Ms. Hardesty? Seeing none. Is there no further public comment? I believe, Carla, that's everyone in the waiting room. Is that correct?
Yes, sir, that is.
Very good. We're going to close public comments and move this into the committee. Committee members, you've heard all about the bill. Would anyone like to move the bill?
I'll move the
Senator
bill.
Bouchard. Thank you very much, Senator Bouchard. Yeah, it's easy to go through page by page. There's only one page, committee. I would be persuaded that perhaps we don't need to add the audio to the format this time, simply because audio can now be coded by time taken on the audio. And I think that's a valid point. I think that we would be premature in trying to address that right now. Certainly if there's a committee member that disagrees with that, that's fine. But I think that the method that's coded by now is probably adequate and probably sufficient to cover. Any other comments or suggestions or amendments by the committee? Senator Hutchins, go ahead.
Thank you, Mr. Chairman. You kind of broke up there a little bit, and I didn't know if you were saying we can remove the audio or the audio visual. Can you restate your comment?
I can. I'm sorry. I have a terrible internet
That's okay.
connection here.
That's okay.
I'm in the basement and I hate this. We talked about during the discussion, perhaps adding audio. And I think that there's probably not a need to do that, at least in my humble opinion, in my mind, is I think that's probably covered right now under the way that practitioners code. They can code the audio or a telephone call based on the amount of time that they spend. And that's a separate way of coding. And that's a discussion for a whole nother day. I think that the bill is probably sufficient with the audio visual portion that's in there now. And that's my suggestion. Certainly, if someone else on the committee feels differently, we can add the amendment if you'd like. Senator Hutchings, follow up.
Thank you, Mr. Chairman. I kind of like the audio being there, but I'm in the position where I'm going to vote no on this bill. I listened to the testimony, understand both sides, but I do see a need to possibly wait to see where the federal government is going. Especially with the enforcement policies that we have out there. I want to read more on that before I jump into anything. So that's pretty much my stance. I don't want to put the cart before the horse. I'd like to have us wait. I love the thought of telemedicine, telehealth. I think it's a valuable tool, but I think we should wait on this. Thank you, Mr. Chairman.
Thanks, Senator Hutchins. Senator Furphy.
Thank you, Mr. Chairman. So currently, the way I read it, audio is in there on line 4. So I don't think we're proposing removing audio. Am I reading that correct?
You are correct. We're not talking about removing audio at all right now.
Okay. Mr. Chairman, then follow-up question. With regard to waiting until we have federal enforcement actions, that could be a significant time, my understanding is, before that happens. So I'm inclined to go ahead and approve this bill. And if we need to correct it in the future, we could do so. So thank you, Mr. Chairman.
Thanks, Senator Furphy. Further comments by committee members? Oh, Senator Bouchard, there's the hand. I like the hand.
Thank you, Mr. Chairman. So the suggestion that we wait because of a lack of enforcement, I mean, there are so many things that have a lack of enforcement in that are codified. What will happen here is if we have a disruption in service or some reason that something just didn't work right, we're going to find out about it by having a rule in place that says this is the way we're going to do it. So, I mean, that's how we find out when things are not working right, when we actually make a rule and says everybody has to play this way. And then they don't play that way, and then we're going to find out. So I think it's a good bill. It moves us in a direction. We should be leading on this, not following the federal government. Telehealth has expanded exponentially under COVID. As a matter of fact, I'll profess that I've been a patient on, not for just for my blood pressure meds, to visit with my doctor. It's great. It saves everybody a lot of time. But under the mental health idea, there are so many things that happen on mental health where somebody may be more comfortable talking about something on the phone or on a telemed setting that maybe they would not reach those the goals that they have to if they were in person. I mean, there are those dynamics as well. So I think we should leave it up to the professionals and let them decide how they're going to treat. And this is a good bill. What this does is it makes the playing field even, allows telemed to move forward. And I got to tell you, anybody who's been on this committee, I have, And we have talked about telemed until we're blue in the face. The only positive thing that has come out of COVID is the telemed. We have advanced it. This is a step in the right direction. And and specifically on the audio, I think the bill's fine with the wording that it is. But yeah, I think it's a good bill. I think we should support it out of this committee. Thanks.
Thank you, Senator Bouchard. Perhaps we could start calling ourselves the Smurf Committee. Blue in the face. Senator Hutchins, final comments.
Thank you, Mr. Chairman. I just wanted to make it clear, I'm not waiting for the feds because I like to follow the feds. I think I've made it very clear. I don't like the federal government being in any of our state business, but you guys have done this. This is the way we started our business. So now we have to be under the umbrella of the federal government when it comes to Medicare and Medicaid. I don't like to be a follower, and I don't necessarily need to be a leader in cases like this. I don't like regulating what companies will do, private companies. And I think this reduces competition because we are making the playing field equal. In life, the playing field isn't always equal. Sometimes a company offers better services, and I want to go with that one. So that's part of the reason for my no vote on this particular bill, not wanting to necessarily wait for the federal government. It's just that if they're in the works on something that will make this process better in the future, why do this when we're going to get a mandate from or follow the federal government in the future anyway? That's my point. Thank you, Mr. Chairman.
Thank you, Senator Hutchins. Hand in the corner, Senator McEwen, go ahead.
Call for the question.
Thank you. The question has been called for. Will you please take the roll, Carla?
Thank you, Mr. Chairman. Senator Bouchard.
Vice Carla, can you please announce the bill number before you take the roll?
I'm sorry. Thank you, Mr. Chairman. The motion is for due pass on Senate File 52. Senator Bouchard.
Aye.
Senator Furphy.
Aye.
Senator Hutchings.
No.
Senator McCune.
Aye.
Chairman Baldwin.
Aye.
4 ayes, 1 no.
Thank you very much, committee. I believe Senator Furphy is still in agreement, unless he shakes his head no, that he will manage this on the floor. With the benefit of the added testimony from many of the committee members, if you need help answering questions or just moral support, we have a lot of good moral support on this committee. Is that okay, Senator Furphy?
Yes.
Thank you very much. It looks as though we judged appropriately. We're not going to get to the next bill. We actually went over on this bill. I thank you to all the presenters. I would thank Ms. Curran, her four-legged friend that came in and said hi to us for a little while. He didn't get to speak, but I suspect we'll see him again down the road. Thank you very much, committee and presenters. We appreciate all your time. And now, committee members, you can make your way upstairs from the committee room to the Senate floor, as we would in the old days. Thank you very much, and we will